Hello, everybody. Welcome to Conversations in Health and Care Improvement. My name is Pedro Delgado, Vice President at the Institute for Healthcare Improvement, and today we are very excited to introduce a topic that is relevant to all of us, that benefits all of us, and for which all of us suffer unless it's proactively addressed, and it's equity. We'll get to that. We'll get to our brilliant guests on today's podcast. But before we do that, Amar, why don't you say hi? It's a privilege to be with you once again for another episode of Conversations in Health and Care Improvement.
Thanks a lot, Pedro. What a joy to host these conversations. They've been so insightful so far, and I've learned quite a lot from our wonderful guests that have shared their learning and wisdom so far. And actually, Pedro, you and I have spent 3 days this week together already. So what a fantastic way to keep the conversation going. I'm really thrilled about the topic of equity today because it's gathering much more momentum, isn't it, in the health and care language and lexicon, really thinking about that element of quality and how we can make sure that we're paying as much attention to that as every other aspect of quality. So why don't you introduce our great guests, Pedro, and then we can take it from there.
That's fantastic. So today we have two very, very special guests in Bram Wispelwey and Komal Bajaj from Boston and from New York. I will ask them to do their own intros, but I will say something very brief that may trigger some things for them, maybe even something of an emotion. So Komal, for you, I will say, health equity means going back to our humanity, which is a quote from one of your recent blogs. And Bram, for you, I will say reparative approaches to institutional racism. So, Komal, why don't we start with you? Tell us a bit about yourself, what equity means for you, and why it matters. And we'll do the same with you, Bram.
Yeah, thanks, Pedro. And, what a delight to be here with all of you. I mean, when you say, Amar, that you've had the opportunity to hang out together for over 3 days this week, that brings me a lot of joy. And I'm like, oh, I'd love to hang out with you too. So I'm glad to be here. My name is Komal Bajaj. I am an OBGYN geneticist by clinical background, and I'm honored to serve as Chief Quality Officer for 2 hospitals that are located in the Bronx, New York, that are part of the municipal health system for New York City. I also serve as the medical director of sustainability for the health system. And so, Pedro, as you mentioned, I really look at thinking about health equity as what are the structures and processes related to healthcare delivery that help people live their best life, whatever their best life means for them. And take a very person-centered approach to thinking about health equity. And so, as you mentioned, going back to humanity, in lots of mission statements, in a lot of web pages and titles, there is a description about, these very moving words on what each health system or each healthcare delivery organization is trying to accomplish. And at the end of the day, it's about the people, both the people that work in those environments and the people that are served. And so for me, it's about each human, each day, each interaction. And I can't wait to talk a little bit more about some of the structures that we've built to help make that happen.
Beautiful. Bram, what does equity mean for you? Tell us a little bit about yourself, and then we'll get into some of the questions.
Thanks so much, Pedro and Amar and Komal as well. Great to be on with all of you. So my name is Bram Wispelwey. I'm clinically trained as an internal medicine doctor, and I work as a hospitalist and teach at Brigham and Women's Hospital, Harvard Medical School, and the Harvard Chan School for Public Health. I'm also a public health practitioner. So for me, equity, you really named it well there, Pedro, because I think while equity is very much a future-oriented project, it really requires looking into the past, right? And health is always a place-based activity, and there are histories here, important histories of successes and struggles, but also histories of oppression that really determine, right, inequities, which are not just differences in health outcomes, which are disparities, but really are ones that are rooted in social, historical, political, and economic injustice, and therefore, really require, right, in a sort of moral lens, repair, right. So I think that part of it is really, really important to me in terms of thinking about what it means to me and thinking about how we build, healthy hospitals, and really build trust between patients and communities we work with.
Fabulous. Thanks, Colin and Bram. For our listeners, I think most people will probably be coming to this conversation with an understanding and awareness that inequities exist. I guess for many of us, it's difficult to know quite how we might go about understanding those and addressing those, particularly when you start to understand the deep structural aspects of society and organizations that are perpetuating these inequities. So I wonder whether you could help us learn from a story, an example of something each of you have led. What did you do? How did you do it? What did you learn from trying to tackle something real that you saw that was inequitable? Komo, I don't know whether you want to start us off with something.
Yeah, thank you, Amar. I really, appreciate that. It's almost like we know they exist, and then when you go looking for them, you might find inequities in some of the most surprising places. And so I'll sort of pick up on that thread by talking a little bit about our journey to ingrain equity into performance improvement activities. And so, there's a lot of amazing improvement work that happens across the globe. People will, improve certain metrics, decrease infection rates, improve, the outcomes in a particular area. And one of the most surprising things, Amar, for example, is that we found that, we had made a substantial decrease, if, for example, in infections. So much so you celebrate, you're high-fiving, pizza parties, the whole sort of multi-pronged interprofessional approach that, rightfully teams do regularly, and they should do regularly, until we began to look at various structural barriers to care, and in this case, language and language preference. And when we stratified the outcome data, what we realized was that there was really a gap, that there were certain populations of individuals who did not experience similar gains. Now, as we have really looked at this concept of looking at outcomes stratified by a potential structural barrier, that could be things like language preference, race, it could be time of day, because we all know that health systems operate differently depending on time of day. What we found is that 1 in 5 projects, right, which had experienced favorable outcomes, 1 in 5 projects, there was an intervention-generated disparity, meaning certain groups did not experience the same gains. And so, Amar, you mentioned sort of a micro example, but what we're realizing now over hundreds and hundreds of PI projects that this beautiful, important work that is ongoing needs to be looked at itself, because oftentimes we see that there are gaps. And only when we look for them, right, as I mentioned, sort of surprisingly, right, you find these gaps, can you then implement additional tests of change to begin to close those gaps?
I mean, I think, it brings to mind something really similar, Como, when you're talking about, really, you have to look for them. You might be surprised where you find them. I mean, the example that comes to mind for me, and, there were many other folks involved in this work, including Dr. Michelle Morris, who's currently acting commissioner of New York City Public Health and Department of Hygiene, Mental Hygiene. So this really goes back to when I was an intern, right? So I was doing my training, my residency training, and what we were noticing, and it was only something that those of us who were training could notice, right? Attending doctors only worked on one, unit or another. But what we saw, because we rotated through the different units, is that patients of color, right, Black patients and Hispanic patients, Latina patients specifically, were not being triaged when they came in with heart failure to our specialty cardiology service at the same rates as white patients. And it was just anecdotal, but we started talking. We're like, are you noticing this? You know, we're working on both these services. We're seeing different patient populations as we're doing this work, as we're doing this clinical work. It was just that act of noticing, which was in many ways primed, right, from what was happening in the United States at that moment and the movement for Black lives. But we saw it. We started looking into the data. We found that yes, we really confirmed that this was happening, and then that really spurred a movement that was really hospital wide, you know, in many ways, to think about how we can address this inequity, how we might even repair this inequity, and what other, right? Noticing this has led to a broader movement to say, what might we be doing in this department or this division that is also generating inequities in the hospital? And so more and more of these are being documented, and then more responses are being able to be taken as a result.
Bram, you know, something that you mentioned really, you know, stood out to me, and that powerful example, which I know has been shared in a lot of different places, is definitely one to look at if you as a listener aren't familiar with it. You know, this idea of, at the end of the day, data is what drives decision making. It drives resource allocation. But oftentimes, long before these hunches, these anecdotes from both patients and staff can be very, very telling, right? As it relates to, you know, different barriers that we may not otherwise think about. And so I just want to sort of spotlight, right, that oftentimes just asking people who are in the middle of this work, you'll often find, you know, really opportunities then to go after the data, just like you did in your example.
Absolutely. And I think what's important there too to remember about data, right, is that data and facts, you know, as the social epidemiologist Nancy Krieger always says, they don't speak for themselves. Actually, you know, you need those, you know, in this case, you know, sort of anecdotal hunches, right, qualitative experiences, discussing with patients and communities, right? You need those theories, causal chains, the frameworks already that are built out of people's real lived experience in order to ask the right questions, in order to analyze the data in a way that's meaningful. Because I think sometimes we think about, you know, especially in these big data sets, that, you know, this is a very objective process, but it's really not. And if we don't have that qualitative, you know, work and that, you know, those examples from community members, from communities, their lived experience, and how deep that often goes, you know, we're often going to really just miss the boat on the data front. So I mean, I couldn't agree more. Like, I think those things need to be, you know, they need to be working in a sort of positive dialectic where we're doing both, right? We can't sort of just think about this as a top-down data approach. It really has to also come from people themselves and what they're experiencing.
Yeah, I really appreciate that. And I think that, you know, as the conversation continues to mature and we learn more about health equity and health inequities, right? And some of the concerns around data, right? What we found locally is that through this work, through really listening to people, some of our structures and systems, including our electronic health record, have been modified to make sure we get, you know, as close to the truth as possible, make sure we have real data integrity, add certain fields that we didn't have before. To your point, right, that we really begin to understand what does it take, right? What is sort of the totality of the structures that promote equitable care?
I'm very tempted to go straight to a couple of the actual tools that you have developed. But I do want to ask you a question before we go there, and I don't want to dwell in the past, of course. We are here, and we're alive, and we're talking, and we're living in the present, and trying to shape a better future. But it did take a long time for us to acknowledge that within the 6 dimensions of quality, equity was there. And equity had to be looked at with the same level of detail and interest and proactivity than safety, for example. And we just didn't. It took us 10, 15 years to actually get to grips with the importance of the people that were being left behind and the suffering behind that. And now we're trying to accelerate progress in that direction. And I think I personally am very grateful to people like the three of you and the people out there listening to this podcast, because I know there's a lot more proactivity. But do you have any recommendations to ensure that there is less of a 1% chance that we go back? How do we keep moving forward? What do we need to do to keep the momentum in this conversation, and potentially to increase the momentum of the, not just the conversation, but the proactive action, rather than just stating the problem, working on the solutions? So any recommendations for our listeners in terms of how to continue moving forward and potentially move forward even faster?
So, Pedro, thank you for sort of anchoring us in this, sort of we're in this moment, and as we look to the future, there's so much more to be done. I reflect on thinking about I'll start with my own personal journey, and then again, sort of think more broadly, right? It's easy to hide behind mission. It's easy to hide behind, well, I'm doing this work every day. And I will say that it took a real hard look at my own assumptions, at my own biases, right? To really, unlock my thinking in a way that I know that I myself can never go back, right? And so that's just one person, but that sort of reflection that is happening in healthcare teams, in leaders, decision makers, I think those aha moments are really crucial, right? That sense of acknowledgement, but also acknowledging these gaps exist. And I myself, as a physician, as a leader, right, can think differently about this. I think that's kind of, for me, one key piece. I think another key piece is this idea of capacity building, right? It's one thing for people to have these aha moments and realize that there is more and to be done and the willingness to do it, but really the pathways to how to do it. And so, I remember in the earlier days of our experience, and again, like Brahm, this takes many, many people to do this work, when we would start talking about equity lenses or how did structural bias play a role, there were some pockets where there were crickets, not because people didn't have thoughts or reflections, but because there needed to be a comfort and a culture that supported those conversations. And so I think for listeners, it's about thinking about your own self, but really what is the culture and capacity building capacity of those that are involved in this work, right? And familiarity to then be able to have those rich, meaningful conversations, which then results in this sort of people-powered action.
Yeah, I mean, I think, my experience has been really similar to what you're describing, Komal, and I think that piece that you mentioned as well that's so important is really making it clear that there are ways forward, that there are interventions, there are steps we can take to mitigate these things. Because I think, one thing we see over and over again, especially when you're talking about big historical structural factors, right? They seem often, that they can't be changed, or they're too big, right, for any sort of group or institution even, or certainly individuals. And I think, showing that there are steps that can be taken really at every level of how the healthcare system is operating is really, really empowering then for getting folks involved. Because like, as you mentioned, Kamal, people are noticing these things, they see them, but they often feel powerless to change them, right? Or they feel like there isn't motivation within their institutions to change them. And so I think any examples that can be marshaled, that can be enacted within these institutions can really, really be empowering. And I think that's certainly something we've seen, where more and more people are looking to document these things with an eye towards changing them, right? Not just, publishing the research, and doing that part of it, but saying what steps are we going to be able to take afterwards in order to make this change within our clinic, within our hospital, within our department.
We know, don't we, that when we're thinking about quality improvement work, co-producing it with the people who are affected by the work gives it a much greater chance of success. It's more meaningful. We get a greater diversity of understanding of the system, better ideas, and actually, our own work in East London suggests it's 3 times more likely to be effective if we're involving people right through the process. And I just wonder how that's different and potentially harder in work tackling inequities, because here we're thinking about and trying to reach people who sometimes don't come to our doors, who haven't engaged with the care that's being provided, who have poorer outcomes, and we're not sure why. And I wonder how you might be able to offer some help and tips to our listeners and watchers about how can you start to have a conversation, because I'm imagining it starts with some guilt, it perhaps starts with some shame, it may even generate some anger that this inequity exists. How do you go from there to a trusting relationship that allows us to work together to co-produce better systems? And Bram, I know the ARC framework is one you've used and have found really helpful. So I just wonder whether you could bring in tools like that to help our listeners think about how to really deeply engage with these groups of people who might be being left behind and how to build that trust.
Great, thanks so much. And you mentioned, right, the Healing Arc framework, which is something that Dr. Michelle Morse and I really borrowed from Sandy Darity and Kirsten Mullen, right, who are scholars who are working on federal reparations for the Black descendants of enslaved people in the United States, right? And the model is it's simple, right? The acronym is ARC: acknowledgement, redress, and closure, right? When you have these historical injustices that are there, right, to think about what is a reparative process, a restorative process. And in our case, right, where we documented that our hospital was driving these inequities, right, we set up our study in such a way to really understand what were we responsible for as a hospital. That we realized we had done harm to patients in terms of access to care and specialty care, and so we really wanted to take that seriously. But as you mentioned, right, that required working directly with impacted community members. So we worked with some of our community partners and clinics to really recruit what we call a community wisdom council, right? So these were folks who have either been patients, right, or had family members who are patients. Who are impacted, right, or have been long-term activists and organizers around health inequities and injustices in communities to do some of this hard work. And sort of what we first had to do, and I think we scheduled a 3 or 4 hour meeting to do it, was really explain what we had found and to really just start with that and sort of owning up to what we were responsible for, and then start to work together on this ARC journey, right? How do we go about these things? And at each step of the way, right, we were working and meeting with this Community Wisdom Council to figure that process out, ultimately developing, a repair-based intervention that's still sort of in a pilot phase. But I think it was, it's hard for all the reasons you mentioned and more, right? There's the systems are not set up to do this work, right? Working with people outside the institution, right? Community members, and the time involved, just the basic parts of scheduling, right? We pay all of these Wisdom Council members for their time and effort, right? Because they're providing real advice and solutions and wisdom that we don't have, right, within our hospital walls, right? And so really paying them for their valuable time for that consultation.
Amar, I really want to, I really appreciated Bram's comments, and I really want to sort of spotlight the co-production element that you described and really commend the work that you are leading and sort of, ways to do that. And as you mentioned, sort of the impact of co-production. Bram mentioned the ARC framework, which is a phenomenal sort of way to think about things. I want to, again, sort of acknowledge the structures that already exist and how we can sort of relook at those structures and really sort of supercharge them to promote health equity. There is a community health needs assessment that is a requirement to be done. There is often a tremendous amount of wisdom. So if you as a listener, haven't seen that or, are unsure where to find that, there's a lot of amazing wisdom in those community health needs assessments. There are other frameworks on how best to engage patients, board members, advisory councils, in the work that we do, and they come from places like the Agency for Healthcare Research and Quality, the IHI, the Institute for Healthcare Improvement, Leapfrog. There are many sort of toolkits that exist on how to engage bodies of people, right, bodies of the public in sort of different ways, and And even I am thinking about a framework on how to better engage and co-produce research, right? A key element in sort of changing how we do things. And so, those frameworks exist. There are many of them, actually. And so, finding the one that sort of relates to your environment, I think is really, really important. Some of the ways that we've been thinking about structural co-production in unique ways is one in the hiring of key roles. And so, each organization has leaders, quality and safety leaders, right? Different kinds of leaders. And while you can't have, sort of co-production maybe at every position, because, there are organizations that have thousands and thousands of hires, right? Think about for your areas or your key leader hires, especially in quality and safety, how you can incorporate patient voice. And oftentimes, like just that one act then will unlock a lot of other conversations about how people can be more involved in design and implementation of interventions.
I'm really keen to build on this opportunity to develop trust through co-production, through co-design, through dialogue as you continue to shape the future. And I want to ground the next question as we come towards the end on the invitation that you may have for people to act and on an offer of hope. So if anybody listening to the podcast is wondering where to start, I think Bram and Komal have given you at least 3 or 4 avenues. One is institutionally, your human resource practices, your development of people practices, and so on, can be a really good place to start to build trust with your people. Clinically, access, experience, and outcomes. So where are we? Where could we be? Who's being left behind? Who's suffering? And one that goes beyond the walls of any institution, which is population health, which is a little more complicated, but anyone working in a health system is part of an anchor institution, and you have an incredible role to play as an employer, as a provider, et cetera, et cetera. So get started. I think it's the message from the 4 of us here. But Bram and Kuma, what would you say to people in terms of hope? What gives you hope from what you're seeing out there around progressing equity work? And do you have 1 or 2 tips and tricks for them as they continue to progress this work?
The data, right, on broken trust, right, on mistrust, on trustworthiness gaps, right, of institutions is sometimes overwhelming and can be very scary. And actually, it was really IHI that introduced me to a lot of that data on where things really stand, right? And that's within employees within institutions, healthcare institutions. That's between communities and institutions, patients and clinicians, right? It's really at every level that we see some of that data. But I think what really gives me a lot of hope is seeing firsthand how trust can really be built, and to see that first and foremost, what our Wisdom Council really taught us is that you really have to show that you're serious about addressing these things, right? That there is a commitment there that is deep, that there's an acknowledgement that the problem is real and it's something you're taking seriously, right? And that has to go beyond words into action. And that's not necessarily easy to do, right? But I've seen the power of when people see that, and when they see you're serious, and when you're making significant strides to address something. That is really the start, right? And that and the trust having been broken or not being there might have been outside of the control of the the institution, right? It's not a question necessarily, as it was for us, of a specific harm being done that we were responsible for, but for all of these historical and structural reasons, right, that trust needs to be built. So I think when you make the assumption, right, that there are going to be trust gaps, it's going to lead to approaches that are going to be trust generating. And once you start that positive momentum, really that to me is very hopeful to see, because you can see, like, if we could just, if this could be replicated, that we would have this sort of trust generating engine behind the work more generally. So even though a lot of the data on trust is scary, I think, there are some, I wouldn't say simple, but ultimately straightforward, right, if the will is there to accomplish.
Yeah, Bram, you mentioned the trust gap, which is very, very real. And I think that, in sort of acknowledging that trust gap exists, learning more about that trust gap prior to design and implementation, I think is a crucial way to then, craft programs that have a piece, specifically addressing trust and communication gaps. I think another sort of key thing that comes to my mind goes back to that idea of back to your humanity, right? How great do we feel when we have given a suggestion or a thought, and there are things that happen with that thought or that idea, and you sort of, even if you're not involved in the implementation, you hear back, hey, that thought, that suggestion that you made helped do this or shape this. Or it might be, thank you for the thought and suggestion. Here's why it's not the right time, or why that may not be applicable. And so this idea of, having people involved in design and implementation, I think is the best form of co-production. But as Amar mentioned, sometimes people aren't wanting to engage. But sometimes they'll give you a mouthful, or they'll post on social media, or they'll tell you via survey their sort of uncut thoughts. And I think that in general, healthcare delivery, and my institutions included, could do a better job of that loop closure. Because what a beautiful feeling for someone to know, what, I was heard. And even if something couldn't be implemented, it was considered, right? And so I would encourage, those that are listening to really think about, you do these amazing programs, you stand up these things, how are you closing the loop with people? And so deliberate attention and resources in that loop closure, in my view, can really help with trust making for the future.
Thank you both so much. Some of the things I'm really thinking about and taking away from this is, the invitation to really begin with a deep introspection and considering our own values, beliefs, and assumptions, and what we have power to do differently and hold true to. The invitation to really connect the data to people's lived experience and use that to get a much richer understanding. And then to really find ways to build trusting relationships. And I wonder, for me, a lot of that, those are things that we strengthen and utilize in quality improvement work, in the use of improvement science. So there's a real opportunity for people listening to this who may have used quality improvement to improve flow or safety or workforce well-being, to think about how you'd use that way of building trusting relationships, to understand the system in its full extent, to bring quant and qual data together to get a richer picture, and to close that loop you were just talking about, Kamal. So that's what I think I'm taking away from this conversation. So thank you both so much. Pedro, your thoughts and reflections on this fantastic, rich dialogue.
Yeah, very little to add, and just an acknowledgement and a word of gratitude to many. So the acknowledgement is that a lot of the audience of this podcast is global, and for that globality, many are from the UK and specifically England. So we just want to take a second to celebrate. And Amar, I'm going to embarrass you here, the Pursuing Equity work that you're doing across East London. To celebrate the Race and Health Observatory work through the Learning and Action Network to close maternal morbidity and mortality gaps that are race-related. Bola Owolabi's team at NHS Inequalities team, who are doing incredible work through the Core 20+5 agenda. The collaborative meeting that they organize. I mean, I could go on and on. Amar could go on and on. We could spend 20 minutes on that. So let's celebrate the work that's done by the people on this call for sure. the work that you guys are doing out there as listeners, and let's continue to build. If you're listening and you're not involved in an equity project, get involved. If you're wondering where to start with yourself, as Amar reminded us. If you're wondering about your data, accept imperfection, but move on to the next stage. And most importantly, seek support. You'll find partners in your system that will want to talk about this. You'll find us for anytime, so just reach out. If you need an ear to pick and a reflection to have. And Akuma, Bram, I'm inspired by the work that you're doing, and I'm hopeful that we together and collectively will continue to close this trust gap. And maybe if we reconnect in a podcast 10 years from now, we'll be celebrating the work and bringing data to show how these gaps have been closed. And we are living under a different reality, under a different social climate, and under an even more dignifying and loving set of health system interactions. So thank you.
Thanks. What a rich and wonderful dialogue filled with ideas and hope from the work you're both doing. So Komal, Bram, from both Pedro and I, and from all of our listeners, a real thank you for sharing your wisdom and ideas and insights with us today. Thanks so much. And to everyone who's joined, I hope you've enjoyed the conversation, and we look forward to seeing you on another episode of Conversations in Health and Care Improvement very soon. Bram, Komal, thank you so much.
Thank you.
Thanks so much for having us.